There is something happening in examination rooms across this country that most people never question. Your doctor schedules a routine screening, you feel perfectly fine, you go, you follow instructions. And sometimes, that single decision sets in motion a chain of events that leaves you worse off than before you walked through the door. Not because your doctor made a mistake, but because nobody told you that the risk and benefit calculation for certain tests changes significantly after the age of 70. I am Dr. Hiroshi Nakamura. I have been practicing internal medicine and geriatric health for over 30 years, and I have sat with patients whose lives were genuinely disrupted not by their illness, but by what happened after a routine test found something. I want to talk to you about that today clearly, without alarm, and with the kind of honesty that a 12-minute clinic visit rarely allows. Before I go further, I want to say something important. I am not asking you to distrust your doctor. Most physicians are careful, well-intentioned people working within a system that rewards finding and treating problems. What I am asking you to do is understand how that system works, and to understand one concept that changes everything once you are past 70. It is called the screening math. When you are 50, routine screening makes clear biological sense. You find a small problem early, you treat it, and you have 30 or 40 years ahead of you to benefit from that early detection. The numbers support it, but after 70, three things shift in a way that most patients are never told about. First, many abnormalities and slow-growing conditions will never cause symptoms in your remaining lifetime. You would live with them, not suffer from them. Second, your body is less resilient than it was at 50. Procedures that carry small risks in younger patients carry larger ones in older ones. And third, there is what I call the cascade effect. One abnormal finding on a routine test triggers a follow-up test, which triggers a biopsy, which triggers a procedure, which triggers a complication. I have watched this cascade take patients who walked into my office feeling healthy and leave them feeling broken, not because of their disease, but because of what the system did next. Stay with me here, because what I am about to share is not meant to frighten you. It is meant to give you the tools to ask better questions. The first area I want to address is routine colonoscopy after the age of 75. The United States Preventive Services Task Force, which is the body responsible for setting national screening guidelines, recommends against routine colonoscopy screening in average-risk adults past the age of 75. This is not a fringe opinion. This is the official, evidence-based position based on data from large populations. And yet I still see patients over 75 being scheduled for them routinely. Because the system does not always slow down to ask whether the benefit at this particular age still outweighs the risk. Let me explain what that risk actually looks like. Colonoscopy perforates the bowel in roughly 1 in every 500 procedures. In a younger, resilient body, that is a serious but often manageable complication. In a 78-year-old body, a bowel perforation can mean emergency surgery, a prolonged hospital stay, and a recovery that the body may never fully complete. Beyond the procedure itself, the preparation required before colonoscopy involves a powerful buccal clearing agent that causes significant fluid and electrolyte loss. In older adults, this preparation alone has sent patients to the emergency room with dangerous drops in potassium and subsequent cardiac arrhythmia before the colonoscopy even happened. I had a patient named Margaret, 78 years old, sharp, active, walked every morning without fail. Her previous physician had scheduled a colonoscopy because she was 6 years overdue. Margaret felt completely well. She trusted her doctor and she went. The bowel preparation alone destabilized her heart rhythm, and she ended up in the emergency room before the procedure could take place. She did not have cancer. She had a routine screening that caused a real medical crisis. That is not preventive care. That is harm caused by good intentions and an outdated protocol. If you are over 75, have no symptoms, have a history of clean colonoscopies, and have no family history of colorectal cancer, it is reasonable to ask your doctor whether a simple annual stool test might accomplish the same goal with far less risk to your body. That conversation is worth having. The second area concerns aggressive cancer screening in the late 70s and beyond. I want to be very precise here because this is the part most likely to be misunderstood. I'm not telling you to stop all cancer surveillance. I am telling you that aggressive screening at advanced ages leads to something called overdiagnosis, and overdiagnosis leads to overtreatment. Studies published in respected medical journals have shown that a meaningful proportion of breast cancers detected through mammography in women over 70 are slow-growing and would never have caused symptoms or shortened the patient's life. But the moment the word cancer appears in a report, the system responds. Biopsy, surgery, radiation, chemotherapy. Each of those carries real risks and real side effects in an aging body. The same dynamic applies to prostate cancer screening. Elevated PSA levels are extraordinarily common in older men, and the majority of the time they reflect benign changes, not dangerous cancer. But an elevated PSA leads to a biopsy, and a prostate biopsy causes infection in approximately 5 in every 100 cases. And if a slow-growing, low-grade cancer is found, the treatment offered is often surgery or radiation, both of which can leave a man incontinent and sexually impaired for the remainder of his life. For a cancer that, statistically, would never have caused him harm, I want you to pause and sit with that for a moment. I had a patient named Gerald, 81 years old, retired teacher, quiet and methodical. His PSA was slightly elevated at a routine visit. His urologist recommended a biopsy. A low-grade cancer was found. Surgery was performed. 6 months later, Gerald was wearing adult diapers and told me in the most measured voice I have ever heard a patient use that he wished he had never taken that test. His cancer was the kind a man his age would almost certainly have died with, not from. The surgery did not save his life. It changed the quality of it permanently. If you are past 75, the most useful question you can ask your doctor before agreeing to cancer screening is this: if you find something, what would we actually do about it? And would that treatment make my life better or simply extend my anxiety? The third area is routine cardiac stress testing in patients without symptoms. This is the one that concerns me the most because it sounds so reasonable. Your doctor wants to check how your heart is doing. You get on a treadmill or receive a medication that simulates exercise. How could that possibly be harmful? The problem is false positives. Cardiac stress tests in asymptomatic patients carry a false positive rate that in some populations approaches 40%. That means nearly half the time. The test suggests a problem where none exists, but that false alarm does not stay on paper. It triggers a cardiac catheterization where a thin tube is threaded through your blood vessels and into your heart. That procedure carries real risks: bleeding, vascular injury, and in a small number of cases, heart attack or stroke caused by the procedure itself. And if the catheterization reveals a partial arterial blockage, which is extremely common in anyone over 70 regardless of symptoms, the next step may be placement of a stent. Multiple large clinical trials, including studies that followed tens of thousands of patients, have shown that stents in patients with stable, asymptomatic heart disease do not reduce heart attacks or extend life compared to well-managed medication alone. You have moved from feeling well to a stress test, to a catheterization, to a stent, to blood-thinning medications with their own bleeding risks, and your statistical outcome is no better than if you had adjusted your medication and gone for a daily walk. I would like to know how many of you have ever had a test lead to another test and then another after that. Write yes in the comments. You are not alone, and your experience is part of a pattern that deserves an honest conversation. The fourth area is routine bone density scanning. Osteoporosis is real. Falls are devastating. I am not minimizing that. But here is where the logic breaks down in a way I need you to understand. A bone density scan reveals low bone density. Your doctor prescribes a class of medication called bisphosphonates. You take that medication faithfully for years, and then something unexpected occurs. Long-term bisphosphonate use is associated with a particular type of thigh bone fracture, the very injury the medication was intended to prevent. These drugs are also associated with a painful condition of the jawbone in which the bone tissue deteriorates and does not heal properly. Meanwhile, the single most effective intervention for preventing fractures in older adults is not a pill. It is fall prevention, balance training, removing rugs from floors, installing grab bars, having your vision checked, reviewing any medications that cause dizziness. These practical physical adjustments reduce fracture risk more reliably than medication, and they carry no side effects at all. If you have not yet begun a fall prevention approach, that is where I would direct your energy before agreeing to a bone density scan and the prescription that almost automatically follows it. The fifth area is routine carotid artery ultrasound in patients without symptoms. Your doctor places an ultrasound probe on your neck and finds a partial arterial blockage. The imaging is concerning. You are referred for surgery to remove the blockage and prevent a stroke. That sounds like exactly the kind of early intervention that saves lives. The problem is this: in patients without symptoms, without a history of small strokes, without episodes of vision loss or sudden weakness, the surgery to address carotid artery disease carries a 2 to 3% risk of causing the very stroke it is meant to prevent. The United States Preventive Services Task Force specifically recommends against routine carotid artery screening in asymptomatic adults for precisely this reason. In an elderly patient, that surgical risk is even higher. I had a patient, Robert, 79 years old, living independently, managing his daily life without assistance. A routine screening found a blockage. Surgery was recommended. Robert went into that procedure walking, speaking clearly, and thinking sharply. He came out with a stroke that permanently affected his ability to speak. The blockage had been there for years and likely would have remained silent. But the surgery designed to protect him caused the exact outcome everyone was trying to prevent. This is not an argument against all vascular care. If you have experienced symptoms, sudden weakness, brief vision loss, any episode that suggests your circulation to the brain was momentarily interrupted, you should absolutely be evaluated. Symptoms change everything. What I am describing is the risk of looking for problems in people who feel well, at an age when the tools used to address those problems carry significant consequences. Now I want to give you something practical, because information without guidance is incomplete. There are 4 questions I want you to write down and bring to every appointment from this point forward. First, what exactly is this test looking for, and what happens if something is found? Second, if something is found, what would the treatment be, and what are the risks of that treatment at my age? Third, what is the actual risk of doing nothing, of monitoring rather than intervening? And fourth, is there a less invasive option that provides useful information without the same level of risk? Any physician who values your well-being will welcome those questions. They are not confrontational. They are the questions of a patient who understands that medicine involves trade-offs, and who wants to make informed decisions about their own body. I also want to say something that I think matters as much as any clinical information I have shared today. You are not powerless in the medical system. You are a participant in your own care. For most of your life, the responsible choice was to follow your doctor's recommendations without question, and in many situations that still holds. But after 70, your relationship with preventive screening deserves to be more thoughtful, more individualized, and more honest than the system often allows it to be. The body at 75 has a different relationship with risk than the body at 50. That is not a failure. It is simply biology. And understanding that biology gives you the ability to make choices that genuinely protect your quality of life, rather than choices that protect the appearance of thorough care. The patients I have seen age most gracefully are not the ones who had the most tests or the most interventions. They are the ones who asked good questions, who understood their own bodies, and who made deliberate choices about when to act and when to leave things alone. That kind of wisdom does not come from a screening schedule. It comes from exactly the kind of conversation we have had today. If this was useful to you, I would ask you to subscribe to this channel. I make videos like this specifically for adults over 60 because the information you need to make good decisions is not always what you receive in a 12-minute appointment. Leave a comment below and tell me whether you have ever had a screening lead somewhere you did not expect. I read every response, and your experience may help someone else ask the right question at the right time.